Hello, I'm Carol Ireland, the CEO of Epilepsy Action Australia. This is our Ask an Expert series, and I'm here today with Dr. Jacobson, Neurosurgeon. Erica, great to have you here. Thank you for joining me.
And thank you for inviting me. I'm pleased to be here.
Terrific. So we've got a few questions for you, some from us and some from our patients or clients, as we call them. We know that most people with epilepsy are treated with anti-epileptic medications. I'm wondering if you can tell me when surgery might be considered a good option.
Surgery is usually considered when somebody's tried a few medications and they're still really having problematic epilepsy. Some people will have the occasional seizure and they can manage it and maybe it doesn't interfere with their lifestyle. But if they're having very problematic seizures that are interfering with their lifestyle, stopping them from driving, etc., it really is a good time to consider whether they're a surgical candidate or not.
Is there a length of time? How long would somebody be having seizures, problematic seizures, before they might consider surgery?
It's an interesting question because it can be anything from, you've had seizures for 10 years and everything's just beginning to fall apart. So you can have had surgery for quite a long time, epilepsy for quite a long time. But some people have very explosive forms of epilepsy and that process can be very short in months. So especially with small children, we sometimes see them suddenly have seizures and they go through 2 anti-epileptics very quickly and nothing is working. So that can be a few months to years and years, decades.
So how would you know when you think somebody is appropriate for surgery? Is it the things you've just described there, or are there other indicators?
Mostly it's failure of the medication. Some people have the sorts of epilepsy that simply isn't going to respond to medication and probably isn't going to respond to the sorts of curative surgeries we can do. And those patients, when they've got very badly controlled epilepsy, may then go down a path of the other types of surgery we do, which are designed to improve the seizures but not necessarily cure them. So either failing medication and having something we can potentially cure, that we can find a focus, or having terrible epilepsy and we're just trying to get it under control, better for the family.
Of course, there are many different kinds of seizures and epilepsies. Would surgery be more likely to be a good treatment for certain kinds of seizures?
Yes, absolutely. The very typical sorts of things we see are people who have complex partial seizures, and it's the most common form of seizure we see in adults. And they're people who've often had something like a febrile convulsion when they're young and they develop a scar on their brain. And usually it's in the temporal lobe, and that's where we do temporal lobe surgery for that type of seizure. And it's a very common, specifically epilepsy type procedure. Adults often get other lesions too, so if you have something like a benign tumour or an abnormal blood vessel that is causing seizures, then we can take those out too, and often in those situations surgery is really indicated because there's a lesion that's removable.
So there's something physical here that you can see. Yes. I think you mentioned a scar.
Scarring, lesions, yes, absolutely. They're probably the best ones for surgery to aim for a cure.
So what are the different kinds of surgery that you might be able to have with epilepsy?
Well, we can do little things from just taking out a small lesion, as I said. We can do larger things, and like taking out a whole lobe if you've got an area that's abnormal. So temporal lobe epilepsy is the typical one there, where we take a large amount of temporal lobe out for that. We can do really big operations in some children who have terrible, what we call often dysplasias, where their brain is malformed. We could take out a whole quarter or even disconnect or remove half a brain. So it can be huge. And they're for the focal lesions. And then we've got the other treatments where we look at trying to control seizures. And it's things like putting in a vagal nerve stimulator, which is a relatively simple procedure compared to the other ones we do, or doing a corpus callosotomy where we split the brain to stop the transmission of electrical activity across the brain.
Tell us about the process for being assessed for surgery, from when someone first talks about it or when the doctor first thinks it might be a treatment. What's the process?
Well, it's usually the neurologist who starts, and certainly some neurologists, the epilepsy neurologists, are very well programmed. They've learnt very much to start thinking about it early. So if they have a patient who has failed a couple of medications and the medications are tied to the types of epilepsy and you've got limited options, then they'll often start looking at, is there a focus? Now sometimes patients have obvious foci. They have an epilepsy that says there's something in the right frontal lobe, and they may start that process well before you failed medication. So once the neurologist has decided it's obviously a focal epilepsy or that you failed medication, it's time to start looking, then they'll start doing some more investigations. Now, very early on, hopefully you've had an MRI to make sure there isn't anything in the brain causing it, and that would send you off the path early to surgery. But if you've had an MRI and there might be something there that may be relevant, they may then go down the path of other investigations. So PET scan, putting you in hospital to do long-term EEG and video monitoring to look at what your seizures are like, and see if that matches with the location of any lesions seen on an MRI. And then there are many more complex tests too that you can do, SPECT scans, etc., to try and focus in on epilepsy and a focus.
So our clients have used the term the workup.
The workup,
yes.
Is
this what this is referring to?
Yeah, that's the workup. That's definitely the workup. And really, you don't have to go through a full workup. You know, if you have an MRI with an obvious abnormality that matches your EEG, you may only need that much workup. But when the types of epilepsy or if the EEG doesn't really fit with something on an MRI, because there are lots of abnormalities on MRI you can have that are completely irrelevant, then that's where you'll start going through a longer process and a longer workup.
So the MRI is a really important tool.
The MRI is an important tool, yes. Very
but
much
it's not
so.
the only. It's not the only one.
No. And I think in epilepsy, and we as a neurosurgeon, I see people with brain tumours presenting with a seizure, and those are patients, they haven't had epilepsy but they present with a seizure, and if we don't fix the tumour they will go on to have epilepsy, or you'd say they're having recurrent seizures, which is what we call epilepsy. So they just go straight to surgery. But not every epilepsy patient has an MRI early on.
Mm-hmm. Now, some of the procedures, some of the surgeries you talked about there sound quite invasive, very complex.
Yes.
Can you talk to us about the risk that's involved with surgery?
The risk is very much related to where in the brain it is, and also to the size of the operation. So if, for example, you've got a little lesion, but it's very close to the part of the brain where your motor strip is or the main sensory area is, you can take that lesion out, but there is a real risk to that patient that they could become weak down the opposite side. So if it's very close to an important area, then there are real risks of neurological damage. So we're looking as neurosurgeons at where in the brain it is, how much you can take out, what sorts of problems you can cause. Frontal lesions at the front of the brain, often you can do very large resections without causing really obvious neurological damage to a patient. And there are subtle things that you need to warn people about, like personality changes. But you know, also surgery is big, and we have to worry about somebody reacting to a general anaesthetic, disrupting the blood supply and causing a stroke, infections afterwards. It's not normal to cut into the skin, so these are all very real risks of any form of surgery. So while it's a big undertaking, we're often balancing that against the risk of their epilepsy. And there are many people out there with forms of epilepsy where every time they have a seizure, they're in danger of dying. They have a seizure in a bathroom. So surgery is big, but it's controlled. It's actually relatively safe despite those terrible potential problems, and often much safer than leaving somebody to have seizures.
Sounds like the decision itself is big for the patient and the doctor.
Interestingly, as a surgeon, I find these are some of the easier conditions to consent for, because by the time patients are coming to surgery, they've often had terrible seizures, they've dealt with lots of problems, the epilepsy has affected their life in such a terrible way that I more often see patients who come to me saying, yes, I'm ready for surgery. And I'm going, oh, just hang on, I need to tell you the problems first, then you can make that decision. But it really is balanced against the problems of epilepsy, and epilepsy can really affect people's lives in a terrible way.
Of course. And what would somebody expect in a recovery period after surgery? Again, it's obviously tied in with the type of surgery.
Yes, and the size of surgery, the little things that are superficial and little people recover from very quickly, but something typically like a temporal lobectomy, it really does take it out of you. It is major surgery. I think people have headaches and just aches and pains for a long time. I'll usually tell my patients, you'll feel significantly better in 6 weeks. You see me in 6 weeks, you will be 80 to 90% better. But then you feel the effects of surgery for a long time after that. It really is 6 months to a year recovering from surgery at least.
And are there psychological components to that, Erica?
Yeah, there can be, particularly with things like temporal lobe epilepsy. It is in an area which can disrupt your emotional state, so it's in a part that we take out a part of the brain that is directly involved in how your emotions are processed. So some patients can have a reactive depression that's physically related to us removing that temporal lobe. I think for a lot of people changing their lifestyle is also a real impact on people, and any stress, whether it's good or bad, can create anxiety and depression. So you may think that getting rid of your seizures is fabulous, but it's such a change to what you're used to, and people have to live with a fear of waiting for a seizure that may never come, and it can be quite disruptive. That's another aspect of it, and I'm sure that going through surgery has its own post-traumatic effects as well. I mean, it's a big thing for anybody to get their head around.
Interesting, waiting for the seizure that might never come.
Yes, I know, and I've had a couple of patients who've really been affected by that badly and had to have some really good counselling because they were so terrified of having another seizure and not getting it. So it has a real impact on people.
So if somebody has surgery, it's successful, might they then be able to stop their anti-epileptic medications?
Yes, not everybody, and sort of successful surgery, it does not depend on you stopping your medication. So what we're aiming for in treatment is for your seizures to stop. So generally we wouldn't stop medication straight away. For children and adults, we're often waiting 6 to 12 months to start withdrawing medication because surgery itself can stir up seizures. So we create bleeding and scars, and you want to make sure everything settles down and heals first. So even having surgery, just neurosurgery alone for not having epilepsy, 1 in 20 people will end up with epilepsy from having neurosurgery. So scarring can happen. But from then you will start looking at withdrawing your medication slowly.
You spoke before about people waiting for seizures to come and that sometimes they don't come. But what are the risks, or what's the likelihood of seizures occurring again after surgery?
It really does depend on the type of surgery they've had and what caused the seizures. So people who have a small lesion that's clearly causing an EEG change, they've got a very high chance of their seizures being cured. So 90 to 95% chance of a cure of their seizures and coming off medication. And really I think they've just got the risk of surgery causing seizures. So you've still got a 5% chance of seizures from surgery. Whereas the bigger surgeries like a temporal lobectomy, that risk is 80-85%, the chance of cure is 80-85%, which means, 5 people in a room with temporal lobe seizures, 1 of them is likely to have a bad outcome and still have seizures after surgery. And really of those 4 that are left, probably 2 of them will eventually be able to come off the medication. So we don't count not coming off medication as being a bad outcome. What we want is to control the seizures, and that's if we get full seizure control but you still need to be on some medication, that's a great outcome. So it's about controlling the seizures only.
Sure. And Erica, in Australia, where can you have epilepsy surgery?
Well, look, really most major cities have epilepsy neurologists and epilepsy surgeons. So certainly Brisbane, Sydney has 3 major centres. Melbourne has 3 large centres, I think. So definitely Eastern Seaboard of Australia, Adelaide has a centre, Perth, they've all got centres for neurosurgery and neurology that look after epilepsy.
So are these what we would think of as the comprehensive epilepsy services around the country?
Yes. So
those
certainly,
major hospitals?
for example, in Sydney there are three major hospitals: Westmead, the adults and children, which I'm thinking of as one unit, the Prince of Wales and Sydney Children that stay on one campus, and RPA are our major ones. Lots more hospitals in Sydney, but that's where the epilepsy patients come to for their surgically treatable epilepsy. Yeah.
Are there long waiting times if somebody is assessed as being suitable for surgery? Do they have to wait very long?
That's a great question in COVID times, yes. It's changed a lot. Certainly just the workup process, depending on what's happening, can take a while, but then usually we try and get them to surgery within 3 months if they've been clearly defined as a good surgical candidate. And that often means their whole case will be discussed amongst the hospitals and in a huge meeting that happens once every week where we present our complex patients. So waiting for those sorts of processes, but once we know, we try and get onto it in about 3 months.
Okay, great. Now I've got some very specific questions from some of our clients in their words, yes, if you don't mind me asking. One of our clients asked, can you be fully cured with epilepsy surgery?
You can, but you would want to have a very specific problem that had a very specific EEG change that went with that. So it's those people who have lesions, obvious lesions, they can be cured. But for many of the others, we don't completely understand epilepsy, and there's a lot going on. And you may have had epilepsy for such a long time that there are other places that are being suppressed. We take out one place that's causing a lot of seizures, but another one will crop up and start causing seizures. So yes, if we've got something quite specific and focal, you've really got good potential for being fully cured from surgery, and half of those being off medication completely.
Okay. Now, one person asked if there was any type of surgery for epileptic spasms.
Well, that's a really often a nasty type of epilepsy, and it's often in children, and it's one of our generalised epilepsies usually. So not necessarily. We have had kids with epilepsy spasms where it started as on one part of the brain, and the way it's developed in the child looks like spasms, but by doing an operation, often quite a large operation like a hemispherectomy, they have been improved. But often for spasms, other than sort of for curative surgery, no, but we can do things like corpus callosotomies to stop the spread, and a VNS, which is a vagal nerve stimulator, to try and control them and get to make them less impactful on a patient.
So one person actually spoke about the surgical workup. That's where I learnt that, yes, that term. And this person's been through the surgical workup and not suitable for epilepsy surgery, and asks what other options are there. So I think you've probably just touched on that.
Certainly, yeah, things like you wouldn't want to do a big operation like a corpus callosotomy if you didn't have a good generalised epilepsy. That's a really impactful surgery, but something like vagal nerve stimulator may be appropriate, and that can be very effective in some people, and in others, for reasons we don't really understand, not effective at all. But when your epilepsy is badly controlled, I think trying anything that is not going to have a terrible impact on you is worthwhile, and vagal nerve stimulator can be a very good treatment for some people in those situations in particular.
Now I have to really focus as I ask this question.
Okay.
Somebody asked about stereoelectroencephalography.
Ah, yes. We just say SEEG. It's so much easier.
Much easier.
So much easier.
Much easier. Tell us what that is.
It's actually quite an old thing, which has been done in France since the early 60s. But really, the English-speaking medical world has really only started being involved with SEEG in the last 10, 20 years. It's a very complex way of trying to find a focus for your epilepsy, because if we can find a focus for your epilepsy, we have a potential to cure it. It sounds terrible, but it can be surprisingly effective. So SEEG is basically having an EEG directly into your brain, but that means having electrodes placed through little holes in your skull deep into your brain over multiple aspects of your brain, often both sides. And those are directed according to what your seizures are like at specific parts of the brain to try and delineate where your seizures are coming from. You wouldn't do it with somebody with a generalised epilepsy because you're not doing it as a fishing trip. You're really doing it for people where their epilepsy seems to be coming from an area or what we call a network. And the network can mean you're showing up as having frontal seizures, but there's an area deep in the inside of the brain that networks to that, and it could be coming from a deep point and coming straight out to your motor strip. So you focus on the areas that will connect up with each other and might have it. So areas of abnormality, areas that might connect, and try and hone in on a localised bit of thing. So it sounds terrible, but very effective when you need it.
So much to know.
Yeah, yes, and that's really, you really need some very clever people to direct where we're putting in the electrodes when we do that.
So many considerations. I guess a final question on behalf of our clients is, if your doctor hasn't mentioned epilepsy surgery to you, when and in what way should you raise that with your doctor?
Look, if you're having problems with your seizures, I think you should raise it with your doctor. The concept of surgery is terrifying to many, and for people who are non-surgeons, and that includes neurologists, they may feel that surgery seems too extreme for what someone has. But if either your doctor, your GP or your neurologist feel that they don't want to go down that path, I would ask for a second opinion. And there are complex epilepsy services, and there are certainly very, very good neurologists in all of those complex epilepsy services who will say yes or no. They're not going to make decisions to put you into a surgical program if you don't have a surgical problem. But if you do, and there's a potential for improving your quality of life, it's worth asking that question.
Thank you, Erica. It sounds like there really are some good treatment options for people with drug-resistant epilepsy, and that's very important to know, and that patients can come to their comprehensive tertiary centres and have someone to talk to.
Yes, yeah.
Thank you very much for shining that light on surgery for us.
It's my pleasure.